Assalamu alaikum students. So today we will be discussing glucose handling by the nephron. Why have we selected glucose? We have discussed sodium and potassium and water, and they don't need any introduction in terms of their importance. So how come glucose comes in the focus now? Well, glucose. We all know the metabolic importance of glucose. That's the preferred energy source for the body. However, when we talk about kidney and the way it's handled in the nephron, the very important disease should come to mind, which is diabetes mellitus. And in this particular disease, as most of you know, it's a glucose-related problem, uh, and especially in diabetic type 1, the problem hovers around the lack of insulin. While in diabetes type 2, it's a metabolic disorder and has a host of issues. The bottom line is there is raised blood glucose. So the plasma is loaded with glucose all the time. Remember that in normal human beings, glucose does fill up the plasma after meals, but it's nicely taken into the cells, and hence plasma glucose decreases, uh, and it's a routine thing that the body does after the 3 meals that we take. However, in diabetics, since the problem is either in insulin or the way tissues use glucose, i.e., insulin inst sensitivity, especially in type 2, we see that the plasma glucose sustains at a higher level, and this creates all sorts of problems in the long term. Okay, high plasma glucose is a problem for just about all organs of the body, including the endothelium of the vasculature of the circulatory vasculature. So, what happens in kidney when there is diabetes? Well, of course, when plasma rich all the time, rich with glucose passes through the glomerulus, it filters out its normal filtrate, the filtration fraction, which becomes the filtrate. However, in this filtrate, uh, there is much more glucose than you would expect in a normal person. And when this high level of glucose enters into the proximal convoluted tubule, what you have is, as we'll see, the PCT is overwhelmed by the amount of glucose entering all the time, which is high end on the higher end. So when the PCT becomes overwhelmed, and this lecture is all about that, how does it become overwhelmed? What do we even mean by that? You have glucose coming into the urine. Any glucose which is not reabsorbed at the PCT, so all glucose needs to reabsorb at the PCT. PCT is that last frontier for glucose. The tech which is required for glucose reabsorption in the kidney is all available in the PCT. If you have glucose uh, uh, venturing beyond the PCT, you have a very big problem at your hands. It's called osmotic diuresis. I have shared a clinical vignette in my Facebook page that I've created for you guys, and you can see that there's a big problem. So when you allow glucose to flow out of the PCT into the loop of Henle and so on, glucose then becomes a gangster. It doesn't move alone. It gathers around a lot of water molecules with it, and as you can now imagine, urine volume in this chap will be more. So glucose excretion in urine is not just excretion in urine. It's a lot of water that comes with it, and this is why you have that uh, classical feature, the classical complaint of your patient, of your diabetic, that Dr. Saab, I have started urinating a lot, and even more symbolic, not symbolic, even more characteristic pathognomic symptom would be this chap waking up at night just to use the loo. So this glucose in the urine creates a havoc in urine volume, and this person will, since he's losing a lot of water, he or she gets more thirsty. So the second symptom that comes in, again because of this urine high volume, high glucose content, and the water that accompanies it, will cause water deficiency in the body, and then this chap would be thirsty all the time. Second symptom, second complaint that he does is I feel thirsty all the time. Okay. Third is that he will feel hungry all the time because he's losing glucose in urine, and urine is and glucose is obviously a favored substrate for the body's energy needs. So polydipsia, polyphagia, polyuria. These are the three P's of diabetes, and they all come to how glucose is handled by the nephron. Okay. So, but this is the normal tech that I said, the normal technology that is available. So we are basically focusing on PCT because, as I mentioned, PCT is the place where glucose gets taken up. You can see that this is the luminal border. This is the cell, tubular cell. They've shown a PCT cell, and then the interstitium, and this is where the blood vessel would be. Okay. As you can see, that at the luminal border, you have second reactive transport, which occurs, which basically means that the gradient for sodium, which was created by the ATPase, is used to bring in sodium, and coupled with it, you have glucose, which couples with sodium, and this is the sodium glucose transporter. You have lots of these transporters at the luminal border at PCT, and hence you get lots of glucose. You can have lots of glucose reabsorbed into the cell. Once inside the cell, the glucose then basically crosses the basolateral border by passive facilitated diffusion. So these are GLUT transporters, glucose transporters, GLU for glucose, T for transporter, and lots of GLUT transporters at the basolateral border, which then help glucose come out of the cell into the interstitium. And while in the interstitium, they are then picked up by capillaries via the passive bulk uptake. Okay, so these are the three ways where how glucose, which you have filtered and which has arrived in the lumen, will get picked up by the cell, then picked up by the interstitium, and then picked up by the capillaries. Okay, this is a diagram which shows the morphological change of the GLUT transporter. Once glucose comes, attaches to its site, there's a morphological change, and the glucose then is given into the intercellular fluid. This is a generic slide. It's not specific to tubule. He's just mentioned how the transporter, the GLUT transporter works. Remember, this GLUT transporter has many forms, many forms in terms of its structure, and is not specific to kidney. It's present in many other tissues of the body, including brain. Okay, we've done this. Now there are some important terms with regards to the glucose reabsorption. And we'll talk about this. The number one term is plasma threshold. So basically, this is not specific to glucose only. We are generally describing these terms. So plasma threshold basically is the amount of a substance in plasma below which you will not have any problems of this substance overwhelming the PCT or overwhelming the nephron. Okay, so we are talking more generically now. Any substance which is roaming around in the plasma and has not achieved a plasma threshold, i.e. has not increased to a level to come to the plasma threshold, and it's below that threshold, it will not be a problem for the nephron mechanisms that are dealing with that substance. Once I put in glucose, you will understand exactly what we are saying here. The value for plasma threshold is basically milligram per 100 ml. Please remember this. 100 ml is also said as deciliter. So milligram per deciliter is the same thing. Please note the unit. It's important. The second is renal threshold. So plasma threshold corresponds with a renal threshold. So basically, if a substance has increased in the plasma to a certain extent that it has gone over its threshold, which it basically means that now its amount in the filtrate is such that it is now in the red zone. It's now either has overwhelmed the whole of the machinery which is supposed to handle this substance in the kidney, or it's about to, okay, or has done half of the overwhelming, and maybe some abilities left to still handle it. Again, when I put slot and glucose in on all of this jigsaw, you'll be able to understand better. Okay, so I'll just quickly refer to this generic slide once again. There's no uh, mention of glucose. You see that renal threshold is the plasma concentration at which saturation now starts to happen. So what is saturation? Before that, let me just say that a renal threshold is basically the tubular load of that substance. Okay, what is a tubular load? Tubular load is the physical amount of that substance which is coming into the filtrate, the renal filtrate. It can be calculated by multiplying the GFR and the plasma concentration of that substance. It's given in milligram per, again, deciliter. Finally, you have saturation, the concept of saturation and transport maximum. So this is where I'll take a minute to explain. So there are substances which require, just like glucose, which require transport proteins. Okay, so they come in the PCT, and they now require to bind to a transporter, to a protein transporter, get from one place to another, right? So let's focus on these transport proteins now. As you can imagine, these transport proteins have a finite number. They're not unlimited, right? So if you have a nice normal average amount of this substance arriving at the PCT and its respective uh, protein, carrier protein at the luminal border is available, everything is honky-dory, no problems, okay? However, if you increase this substance in the plasma such that the tubular load, oops, such that the tubular load becomes very high, so high that it now reaches renal threshold, then you would have saturated the transport mechanism, the proteins which are responsible for uh, getting this substance from the lumen into the cell. And then you will have this concept, which basically means that the transport has been limited. The transport mechanism has a maximum. We call it transport maximum, TM. So basically what we are saying is transport maximum is the tubular load, okay, or the renal threshold, where the amount of substance which is coming in the filtrate has risen so much that there are no transport proteins left now to handle the top up, the tubular load, the amount of substance which is coming above and beyond this renal threshold. Okay, and it's given as milligram per minute. Okay, so let's just quickly see that these three terms here. This is the plasma substrate. At about this point in the plasma, the substance say, rose up to 4 milligram per ml in this example, and this corresponded to a tubular load which reached the renal threshold, i.e., beyond which you cannot have any reabsorption of this substance anymore. This is a reabsorptive curve. So things were going nicely along as you were rising the plasma concentration of the substance. Reabsorption or transport of the substance also was taking place. Remember, notice the mg per minute. So it's a time function. So plasma at this, below this 4, was dumping whatever substance it was dumping in it was nicely transported. Again, it's a generic diagram. So, but then this point occurs. Then this point occurs where saturation saturation takes place. So whatever now that the plasma will dump into the filtrate, it has reached its threshold, renal threshold, and at this renal threshold, the transporters have now become saturated. So now there won't be any reabsorption. So line flattens. If you have if you had a excretory line of this substance, that would be from this point to this point, it would show zero. Nothing is excreted because all is reabsorbed, right? But beyond this point, that curve would have shown to increase. So right about from here, if you have an excretory curve, you would have this sort of a pattern. Okay, it would gradually and then in a straight line uh, uh, increase. So whatever now that you are adding of this substance to the PCT, it will simply just throw it away, throw it forwards, and it will come into the urine. Okay. Okay, so we've done this. Now let's slot the glucose in. Okay, so now you will have a clear picture of what we have been discussing. So let's solve this first. In a normal person, the plasma glucose should be less than 200 milligram per deciliter. Okay, please remember this value. Fasting glucose is around 100. So if you, after a 6 to 8 hour fast, go and check your blood glucose levels, it should be around 100. Okay, and that's 100 milligram per deciliter, and it's considered normal. When you have a meal, this glucose can raise normally to 180, 190. Anything which is less than 200 is good. You're good. However, if you have, as you'll see in diabetics, you have even the fasting glucose. It's more than 200 milligram per ml. So this is a problem. Okay, moving along. So plasma glucose is less than 200, which is normal. At this plasma level, the tubular load is calculated. Now remember that this is the GFR, as you know, and this is 1 milligram per ml. So we are going for ml, not deciliter. So 100 milligram per deciliter basically means 1 milligram per ml. Okay. Why have we converted this here? Because ml is here in GFR. So this cannot be deciliter. It has to be converted. Either this has to be converted to deciliter or this is converted into ml. So you should not be confused. And remember to be aware of these units. These are important in these equations. So tubular load also comes to be 125 milligram per minute. Okay, this is the tubular load. So what you have is you have 125 milligram of glucose entering into the tubular fluid in a minute, right? What is this? The transport maximum. Transport maximum is basically the upper end, the top capability of the glucose transporters in the PCT. So 375 milligram per minute means that if you were to increase the tubular load, this one here, to up to 375 or round about 375 milligram per minute, you will not have a problem. Not much of a problem. You may have some glucose seeping through the PCT because literally 375 is not, biological systems don't always follow exact arithmetics. Okay, so you may have a person whose transport maximum is say 370, 372, 374, and then you even have differences within nephrons. So some nephrons are big, with bigger, larger PCT, more transport proteins. Okay, some nephrons are smaller, lesser transport proteins. Okay, so this is an average value. So around below 375 milligram per minute tubular load, things are honky dory, no problems, and things are getting reabsorbed, all of it. By things I mean glucose. Glucose is being reabsorbed. So TM of glucose once again is 375 milligram per minute. A figure, a statistic that you need to be very clear about. Now we solve the glucose intolerant or the diabetic person. What happens to these values here? So you see that plasma glucose is always high. Okay, so the plasma threshold, which was less than 200, has been overwhelmed. It's more than 200. Plasma threshold check. Tubular load now calculated as 250 milligram per minute, which is now the renal threshold. So now you understand that at plasma glucose of more than 200, the tubular load becomes 250 and more and more, which is the renal threshold for tubular fluid, tubular load for glucose. At this tubular load, glucose will appear in the urine. Why would it appear in the urine? Because at this tubular load, so 250 milligram per minute, if you add to your tubular fluid at the PCT, this will overwhelm the transport maximum for some of your nephrons, I beg your pardon, and all of them will be overwhelmed above 375 milligram per minute. This point, why have we differentiated between some nephrons and the others, will come in when we look at the graph. For now, just remember that there are differences in the size of nephrons, the size of the PCT, and hence the number of transport proteins in the larger nephrons as compared to the smaller nephrons. So above 375 milligram per minute, all types of PCTs of all types of nephrons are overwhelmed. Okay. Okay, so we have done this. Now, this is the main graph that needs to be understood. Remember, if you get a question on glucose reabsorption in your SEQ, you will be required to make this graph. Uh, and there's a very straightforward way of remembering how to plot this graph, and I'll tell you along the way how to do that. Now, basically, you are looking at, well, let's always first look at the axes, the y-axis and the x-axis. You see that along the x-axis, he has shown plasma glucose concentration. So the plasma is represented along the x-axis, while the y-axis can be read in any way. It depends on which curve out of the three, the red, the blue, or the green. Which one are you looking at? Are you looking at filtered glucose, i.e. the load? Are you looking at the reabsorption of glucose, or are you looking at the excretion? All of them have been given as a time function, milligram per minute. The plasma glucose concentration is milligram per deciliter. Okay, right. So let's first get rid of the simplest curve, the filtered load, the red line, the straight line. So as you increase the plasma glucose along the x-axis, you see that the filtered load increases. This is where the normal stuff, this is the normal, this is around 100-ish, okay, or a bit more above 100 plasma glucose. And you have this at this point, you have the filtered load of we've discussed this. It should be about 125 at 100 and should be slightly above 125, above 100 milligram per deciliter of glucose. And as you increase the tubular load, you increase the filtered load. Okay, so as I beg your pardon, as you increase the plasma glucose concentration, you increase the load, the glucose load in the filtrate, and it keeps on going. It's an exponential. It's a direct proportion between the amount of glucose in the plasma and the amount of glucose that comes in the tubule. It's a no-brainer. It's a simple thing. Things get tricky when you look at when you look at the reabsorptive curve, which is the blue curve, blue or whatever this color is. It's blue. Okay, so you see that as soon as you start increasing the plasma glucose concentration, the filtered load obviously increases. Okay, and this is where things are normal. So about right here, you have the reabsorptive curve, and everything is nice and everything is being reabsorbed. But as you move along, right about here, you have a threshold. So this is the plasma threshold, and we discussed it's 200. Okay, so below 200, it's a straight line. Whatever you have given to the tubular fluid at whatever plasma value, the whole thing has been taken care of. It has been reabsorbed. It's not flattened. It's a straight line. It's reabsorbed. But above 200, right here, above 200, the curve starts to dwindle. It starts to go away from the red curve. So the filtered load now is such that the reabsorption is not keeping pace with it. As you see that it's now turning to the right, and there is this roundish thing, by the way, called splay. And this is one of the ways of asking this question: why is there a splay in the reabsorptive curve of glucose? We'll talk about this. So there is a splay, the rounding of the curve, and then you have flattening of the curve. It flattens out. Okay. So once again, before the start of the splay, before the threshold, the plasma threshold, which translates into a renal threshold of around 250-ish, as you can see here, right? This is the plasma threshold. This is the renal threshold, the tubular load at which the plasma threshold corresponds to around 250. Uh, Beyond that, this straight this straight curve starts to deviate from the straight line, uh, gets to the roundish form here, and then start of the splay is about right here, right about here, and then the whole thing gets rounded, and here it basically stops playing, quote unquote, and becomes a straight line. So before the splay, everything was reabsorbed. During the splay, something funny happened. We'll talk about that. And after the splay, nothing is reabsorbed. Whatever glucose now you are filtering is basically being excreted. Okay. So before I explain the reabsorptive splay here, let me discuss and just get this out of the way. The excretion curve, the last curve here. So the green curve is the excretion curve. You will notice that green curve is starting from here. It's not starting from zero, and it's rather obvious. You do not give out glucose in the urine normally, so it's absolutely out of any possibility that you will have any sort of green curve or excretion of glucose at your normal glucose level and normal tubular load and normal reabsorption, etc. Okay, it will only happen when you have the thresholds which have been overwhelmed, the barriers which you put in, the levels above which things get overwhelmed. So above 200 of plasma, when also the renal threshold also has been overwhelmed, now the glucose will start to seep into the urine. As you can see right here, you also will notice, the perceptive ones amongst you, that there's a splay here as well. It's not like a straight line. It's the rounding of the curve here as well. So the trickling starts gradually, then it increases a bit more, then a bit more, then a bit more, then it's constant. Then it's just a straight line. So things don't start boom. They basically start bit by bit increasing, then more, and then from here on, it's free flow of glucose in the urine. So there is splay here as well. Well, if you have understood this diagram till now, remember this is like the main question of the university exam: the splay in the glucose reabsorptive curve or reabsorptive and excretion curve. If you've understood this up till now, now let's explain the splay. Okay. Now I'll only talk about the splay. We have discussed this bit. We have discussed these bits above the splay, below the splay. We've done all of this. Now we'll look at the splay. So put your knowledge of the transport maximum into play. Imagine that the PCT is lined by all of these plasma, all of these proteins, which are waiting for glucose to come. Okay, it's just like a big hall, an auditorium hall. Okay, I'll give you an example. The auditorium hall has a big door. Okay, that door into the auditorium obviously will have a finite capacity for participants to go through. Let's say that capacity is uh, 50 students or 50 people coming through uh, per unit time, whatever that time is. Okay. If you have 10 students coming into the auditorium, so it's less than 50, very, they will come in very comfortably. Okay. If you have 40, you still have a lot of space through the door and nothing, no spectacular problem will happen. But as you approach the 50 mark, say 48, 49, now you're testing the waters. Okay. At 50, you have the maximum number of people who can fit in this door and come into the auditorium. Okay. Above 50 will be an issue. Okay. Above 50, you will have only 50 that can enter. The rest will have to wait outside because they can't fit through the door. This is a good example of explaining how the transport maximums work. So the transport maximum, quote unquote, of this door of that auditorium is 50, 50 people per minute. Yes. So now you remember that 375 milligram per minute statistic. So in 1 minute, the PCT, the transport mechanism, all those three mechanisms that I discussed in the first slide, they have a limit. They can deal with 375 milligram of glucose in a minute. Above that, you will have all sorts of problems. Okay, so this is one aspect. The second aspect is that not all nephrons are the same. Some are smaller, some are larger. So check this out. Now that you have reached the threshold, the plasma threshold, and the renal threshold, of course, at the same time of glucose, now the splay will start to occur, which means that those small nephrons, mark these words now, those small nephrons with the smaller PCTs and the lesser number of those transport proteins for glucose, they get overwhelmed first. So right around the threshold value, those nephrons start switching off, and the glucose, which is now entering into their tubular fluid, starts to come into the urine, right? So this is where transport maximum for those nephrons has been achieved. Hence, you see the deviation of this reabsorptive curve slightly now to the right. Okay, the rest of the nephrons, the ones with bigger size and bigger PCTs, they still are fighting the good fight. They still are reabsorbing glucose because simply they have, it's like that auditorium, but it doesn't have one door, it has more than one door, right? So those bigger nephrons are still doing reabsorption, and hence they are uh, uh, the transport that's happening in those nephrons, and the ones who have switched off basically change this curve and make it bend a bit to the right. As you move along, you will see that the bending increases. So even from amongst the large nephrons, the less large one, quote unquote, will get overwhelmed, then more, then more, then more, and right about here, which again corresponds to 375, by the way, if you notice. Okay, 375-ish. This is where everything goes down the drain. Every transporter of every nephron has become overwhelmed. You label this graph here as transport maximum. Okay, and beyond that, the whole thing is flat. Nothing, no more glucose per minute will be reabsorbed, and everything will be excreted. And hence, this is a round thing. This is a round thing. Now, I actually found a book in which this was not rounded, rather, this was like this. This, sharp turn, this. Please do not make that mistake. I have no idea why that book, which is a very reputable book, by the way, extensively referred in these lectures, I will not name it, of course, gave this rather simplistic, or I would say erroneous uh, graph. But don't make a sharp turn, always make a splay. in the reabsorptive curve around the transport maximum for the mentioned detail that I have just clarified. Okay, once you have understood that, just take this curve, the splaying here. So when you look at the excretion curve, you see that there's a very humble start to it. This is basically represented here. Represented are those small nephrons which got overwhelmed in the beginning of the transport maximum for glucose, and they started to dish out the glucose in urine. So glucose will come in the urine right about the threshold, uh, because those smaller nephrons now have already become overwhelmed, and as the tubular load even increases more and more and more beyond this value, you will have more nephrons which are overwhelmed, and they'll start giving out their glucose in the urine, and you'll have this gradually increasing, almost uh, a mirror of this Splay you will have in the excretory curve. And right about here, when you have the transport maximum that has been achieved, you will have a free flow of glucose in your urine. Okay, so all of the glucose comes in the urine. So this is an explanation of these three curves and the very important Splay in the reabsorptive curve and the excretory curve. All right. Now some finishing points. There are some substances which are basically, they have important TMs. One is obviously glucose. Then you have phosphate, sulfate. Look at amino acids. So some amino acids, when they come in, they are taken up as well. And look at plasma proteins. Even plasma proteins can sometimes in some diseases come as such, as a whole. And they also have a transport maximum. They can be sorted out to some extent, but obviously not to a very big extent. Right. Then there are TMs. This also gets, it's not just reabsorption. TM is also applied for all actively secreted substances. Creatinine, remember, if you remember creatinine, we used it for GFR estimation, and PAH, we used it for renal plasma flow estimation. And these have transport maximums, but for secretion. So, minor point. This is very interesting. So you see that substances, up till now, we were talking about substances following a transport maximum, but there are other substances, say for example, sodium and other ions, water. They don't exhibit transport maximums. They get reabsorbed because of gradient and literally the time that is available. So you increase the gradient, you increase the time availability, they will keep on being reabsorbed. Okay, so not everything follows a transport maximum. Not everything is limited. Other things are, well, pretty much unlimited, really. You provide the gradient, you provide the time, and you're good to go. And the rate of transport will depend on, again, the gradient, the time, and the permeability of that membrane. If it's normal, it's normally permeable to that substance. There's no stopping this. Okay. So basically, these are the 3 points. This is called gradient time transport as opposed to transport maximum transport. So these are 2 transports now. Gradient time transport does not follow any limitation based on its protein or any component of its transport, while we have studied the transport maximum kind of transport, which is obviously limited by the amount of transport proteins which are available. Sodium follows a very interesting scenario. Sodium at the PCT is gradient time not limited. I mean, it follows the gradient time kind of transport. So you increase the electrochemical gradient, the permeability is there, and if you slow down, remember, if you slow down the velocity of the fluid passing through the PCT, you will have sort of an unlimited sodium reabsorption, no stopping it, right? However, very interesting, at the DCT, you have lesser number of proteins, okay? And the flow also, it's peculiar over there. And it's not, the availability of these channels is variable. Do you know what I'm talking about? Yep, aldosterone and the Enact channels, the E, sodium, C, ENAC, Enact channels. are those epithelial sodium channels which are basically in obedience of aldosterone. So when aldosterone is available, these Enact channels are inserted at the luminal border, and hence they become sites for sodium reabsorption. But when aldosterone is low, these Enact channels go down, they are downgraded, and then the same membrane will become relatively impermeable to sodium. So there is a transport maximum feature at the DCT for sodium, okay, while it does not have any transport maximum feature at the PCT. An important point to note. All right, this is the reference. Uh, this is you just need to look at the Guyton reference really. This I forgot to edit this out as part of the potassium lecture in my class format. Just look at the Guyton reference. Uh, Check out what BRS has to say about this, and that's that. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.